If you can get the next screen, please. So, pain and bleeding in early pregnancy, it's very common early pregnancy complications affecting up to 20% of the pregnancies. Causes are typically, we divide them into four main categories: either normal physiological causes like implantation, bleeding, and pain. There could be miscarriage, that could be ectopic and or molar pregnancy, and also there is a slight chance it could be cervical causes like polyps or infection. But our main issue is going to be miscarriage, ectopic, and molar pregnancy, and that's what we'll be talking about next. So the initial assessment, when women come with pain and bleeding in early pregnancy, we usually have to assess this thoroughly by an urine pregnancy test that is positive in the unit, taking history, including last menstrual period, the detailed thorough history of the presenting complaint, which is either the pain or bleeding or both of them. Any past ectopics, again, a detailed obstetric history and past medical and surgical history, because this will change the management. Also, the hemodynamic stability, the observation of the patient, the severity of the pain and bleeding, also the gestational age, and whether they've had previous pregnancy complications, like previous ectopic or previous molar pregnancy, and the examination. Basically, examination is the abdominal examination and speculum examination. The speculum and bimanual, of course, to assess the cervix, assess whether there is products of conception, assess whether there is bimanual tenderness, and also ultrasound scan to identify whether there is an intrauterine pregnancy or not, or looking for adnexal mass or free fluid. So now, most of the women coming to the early pregnancy unit are very early in pregnancy, most of them before 8 or 7 weeks. So we have to prepare them that there is a very big chance that we're not going to see anything in the uterus when we do the ultrasound. What we are looking for is basically free fluid, any masses in the ovaries, or any complications that we can identify ectopic pregnancy from. Okay. Salma, can you go to the previous one? No, sorry, next one. Right. So now for the management of miscarriage. I know most of us know this, but because it's different from one country to another, even from one trust to another. So we're just touching base on how it works here. So for any woman going through miscarriage, we offer them one of three: either expectant management, which is basically doing nothing until they pass the products of conception, and then we advise them to do a urine pregnancy test at home. If it is negative, nothing to be done. If it is positive, then they contact the early pregnancy unit again. Or we can offer them medical or surgical management. So choosing what... Hello? Okay. Choosing what method we're gonna use is basically depends on what the woman wants to do. A lot of women doesn't want to do anything. A lot of women want to get the things starts soon. Lots of women use surgical options because that makes it them expect when to see it. But also the clinical status of the woman as well. In the medical management, we offer mifepristol and Myzone, either orally or vaginally. Again, depends on what the woman choose. We just need to prepare them for the side effects of each option. We also offer them, we have to consent them for the medical management, and basically you make them aware that it might not work, there would be pain and bleeding, and they might be unwell. We also offer medical management outside the hospital, so they do not need to stay in the hospital for the medical management. However, if they are above 14 weeks, they have to stay in the hospital. Again, this is in my trust. I'm not 100% sure how it works, but I'm pretty sure it's pretty similar in every trust. Also, we offer them surgical evacuation, or MVA, which is the manual vacuum aspiration. This is done under local anesthetic and done in the outpatient setting, in the colposcopy, sorry. And we also offer it if there is any retained products or incomplete miscarriage. Also, we need to offer women who are Rh negative anti-D. Sometimes you will have a scenario when a woman has had the misoprostol and coming 2 days later with heavy bleeding and pain, and she's in so much pain. We have to reassess them, because in a lot of cases there could be a tissue stuck on the cervix, and that would trigger a vagal response, or what we call a cervical shock. And this is often relieved by removing the retained tissue. If women choose the medical option or the conservative option and they go home, we usually safety net them to return if the bleeding is heavy, or if they are in severe pain or start fainting or feeling unwell. We have to make sure that they are with an adult at home before sending them. And also, most importantly, offer them psychological support, counsel them about how they want to deal with the products after delivery. We offer them services to look after them after their psychological well-being. And then when everything is done, we advise them to do a pregnancy test in 2 weeks. If it is negative, nothing to be done. If it is still positive, we see them again. Then we're gonna move to the ectopic pregnancy, which is the most concerning part of the pain and bleeding in early pregnancy, because we are in 2025 and we still see women die from ectopic pregnancies. These are just numbers to show you how common it is, because we don't think how common it is unless you actually see it. I don't have to go through the numbers. Salma, you can go to the next slide, please. So, diagnosis of ectopic pregnancy can be very tricky, because it's basically a triad of 3: clinical judgment, blood test, and ultrasound findings. Like I said, most of the women come before 8 weeks. Some of them, it's just very early to see anything in the uterus, and when we don't see anything in the uterus, we call it pregnancy of unknown location. That can turns out to be a normal pregnancy later, that can turns out to be a miscarriage, or can be an ectopic pregnancy. So it can be really difficult and tricky. Again, it's a triad of clinical judgment, examining the woman, is doing a beta HCG. Again, it's a serial HCG rather than one result, and an ultrasound. On the ultrasound, we're looking for empty uterus and either adnexal masses or free fluids in the pouch of Douglas. These all things come together to diagnose an ectopic pregnancy. Cervical signs, we're looking for cervical tenderness on bimanual examination, shoulder tip pain, some women come with diarrhea, guarding, rebound tenderness. These are all clinical signs of an ectopic pregnancy. Some trusts use different models to clinically predict what the possibility of a pregnancy of unknown location. We use the M6 model, which is basically a prediction model developed to support diagnosis of ectopic pregnancy. We use variables like history, symptoms, beta HCG, progesterone, and ultrasound findings. This has shown to reduce the diagnostic uncertainty in PUL and improves the triaging between expectant management and the need of intervention. So again, the management of ectopic pregnancy, when it is confirmed, there are either expectant, medical, and surgical management again. Now, before we choose any of these management options, we have to clinically assess the woman, bearing in mind that the woman has to be medically, clinically stable, hemodynamically stable, and also bearing in mind that these are very young women, healthy, and they can be absolutely fine. Their body can compensate and until it can no longer. So most of the women will.
Sorry, Francine, I think you've unmuted. Can you try and...
Sorry.
Yeah.
Can you hear me now?
Yeah.
I'm not sure when I was muted, you know? So basically, women can become very unwell before coming to the hospital. So putting the whole picture before deciding which mode of management you're going to do is very important. We offer medical management, which is the methotrexate, that is only suitable for beta HCGs less than 5,000 and no cardiac activity. Surgical options, this is mostly done in unstable cases which has ruptured. We either do salpingectomy or salpingostomy. Expectant management, these are the very selected cases with no significant pain. They are hemodynamically stable. They come to the unit every 2 days for beta HCGs, and the serial HCGs are dropping. If they are static or the woman become unwell by any means, then change of plan has to be put in place. And we keep doing the serial beta HCGs every 2 days. If they drop significantly, we do it every 7 days until they are completely negative. We also have to advise women about the risk of recurrence, which is 10% in future pregnancy, and advise about contraception. Also, we have to touch on the whether they've had the methotrexate. We advise women to have contraception for at least 3 months because it can be teratogenic. Next, please. So yeah, this is basically the 2 most common presentations in the causes of the pain and bleeding in early pregnancy. Now, the other very common presentation is women coming with severe form of nausea and vomiting in early pregnancy, and this is what we call the hyperemesis gravidarum. So we're going to have a closer look into it. It's basically a severe and debilitating form of nausea and vomiting in early pregnancy. It affects 0.3 to 2% of pregnancies, leads to dehydration, electrolyte imbalance, and weight loss. Sometimes it requires hospitalizations for IV fluids and antiemetics. Now there is an ongoing discussions whether this can be managed in the primary care or in the secondary care. By all means, women that cannot eat or drink anything, cannot keep on top of their hydration, needs to come to the hospital for rehydration and antiemetics. We do assessments using doing bloods, UNEs to make sure that there is no electrolyte imbalance, urine analysis to check ketones in urine, Now might just have changed from assessing urine for ketones, and now we follow what is called a puke score. It's a score assessment to check the severity of hyperemesis gravidarum. We admit them to for IV fluid, giving them either cyclizine, prochlorperazine, and there is also a new medication called Zomvia. Also, it's very, very important that we do a VTE risk assessment score for every woman coming with hyperemesis. Basically, for every pregnant woman coming to the early pregnancy unit, we need to do a VTE risk assessment. It's basically a criteria that we follow, asking the women question, and it does score them for their risk of developing VTE, and then you give the woman the option to give them prophylaxis VTE. Now, dehydration on its own scores them 4. So if a woman continuously coming with hyperemesis and she's severely dehydrated, she would be a very high risk of developing blood clots. So we need to counsel them on this. And the red flags is other options, other differentials of UTI and gastroenteritis. We also have to suspect molar pregnancy. So if a woman is in her early pregnancy and haven't had any scans, we need to scan them to make sure that it's not a molar pregnancy. We also need to consider the psychological impact on women, because it can cause significant distress and anxiety. It limits their ability to work, socialize, or care for their other children. Some women, when they have explored every option of the antiemetics and nothing is working for them, some of them may even consider pregnancy termination. So it really requires a compassionate and multidisciplinary approach for their care. Now, another thing we would be exposed to as junior doctors is the post-operative care for women who've had a cesarean section. Sometimes it can be overwhelming what to expect, what do we look for, because it's you basically go to the postnatal ward as an SHO, you review women and discharge them home on your own. You're the most senior person that they get to see, unless they have a problem that needs to be discussed with a senior. So that can be a little bit overwhelming in the beginning. However, it's like any post-surgical review. These are the things that you need to be looking at. Every woman who've had a cesarean section, 24 hours, we need to check her vital signs, Muse scoring. Is she scoring for anything? Is her blood pressure okay? Some women have a very low blood pressure, but if you look into it, her booking blood pressure is going to be low anyway, so there is nothing to panic from. Pregnancy-induced hypertension, women who has been started on labetalol, then we need to change the blood pressure medication. These are things that we can discuss them in another session because it's a little bit more complicated. However, these are the things that you can review with the senior. Basically, if a woman is septic post-cesarean, then you follow the septic approach. Check if they are on IV antibiotics. How long have they been on antibiotics? Have they had bloods? Have they had inflammatory markers? Have they had other investigations? And if they are not scoring for anything, then we can move to the next point, which is the pain score. Again, we don't expect women to be running around after a cesarean section. However, they should be encouraged to mobilize. After taking the catheter out, they usually get out to have a shower. We give them morphine in the hospital. However, we don't send them home with the morphine, so we need to really check if they are able to cope at home or not. We usually give them, they can take paracetamol, ibuprofen if they are not allergic or asthmatic, and we give them dihydrocodeine, but we don't usually give them morphine. So if a woman is still requiring morphine after a cesarean section, then it needs proper looking into it because there might be something else happening. We also reviewing the wound. Again, like any post-surgical wound, We don't take the dressings off, but we is the wound oozing? Does it look okay? Does the skin around looks okay? Is there any cellulitic changes? These are the things that we need to consider. Also, the uterine contraction. Again, by examination, we need to make sure the uterus is well contracted, because again, the most common cause of maternal death after a C-section, unfortunately, is still the VTE. However, a lot of women come with the secondary postpartum hemorrhage, and that is mostly from a tonic uterus. So we need to really check that the uterus is well contracted before sending them home. And that can simply be done by examination. We need to make sure that the lochia or the vaginal loss is minimal. They are not losing lots of blood. They are still not passing big blood clots. And if there are any concerns, we have to address it or speak to seniors. We also need to make sure that the urine is clear. Now, sometimes it can be very difficult in the beginning because they are still have some BV bleeding. So to distinguish this from the hematuria, it can be tricky. However, if you have any doubts, just keep her longer and monitor it. But we have to make sure that there is no bladder injury basically after cesarean. Next screen, please, Salma. And then the discharge planning is counseling the women. We counsel them about no driving post a cesarean for at least 4 weeks. We counsel them about the analgesia. We advise them on mobilizing and not to carry anything heavier than their baby, to take it slowly, to keep on top of the pain relief, to monitor the bleeding and any signs of infection. If she becomes unwell, if she start to have any foul smelling discharge, these are all signs of infection. She needs to come back. Or, like I said, if she's bleeding more than more than expected, and we usually advise them to put fresh pads on. If they are soaking these pads, or if they are passing big blood clots, then they need to come back. We advise them on the wound, how to look after their wounds. They usually see community midwives in 5 days after being sent home, and if they have any concerns, they would refer them back to the secondary care. Also, women post-Caesarean needs to be counseled about contraception and the interpartum periods before Caesareans to avoid uterine rupture. Advice on analgesia, like I said, VTE prophylaxis risk assessment score is done when the woman gets pregnant and on delivery. A lot of women, any woman who's had delivery has a VTE risk assessment score, whether vaginal or cesarean. But the cesarean women are most probably gonna need some VTE prophylaxis because they've already had a section that scored them for one, and if they need, if there is a score for anything else, they would need at least 10 days. Again, it differs from one trust to another, but some women might need 10 days, others might need 6 weeks. By all means, you counsel them and educate them about the VTE prophylaxis, and then send them with the medications, do a GP letter, explain how they've delivered, what they have started. If the woman has been on blood pressure medication and you've changed it in hospital, you need to make the GP aware. Some women have lost blood and they need a blood transfusion. You need to make the GP aware. If you've started them on oral iron, then you need their bloods to be repeated in 4 to 6 weeks. Again, speak to their GP, and communication with the primary care. And that's very much it.